control, and the third factor is inflammation and fibrosis. So inflammation and fibrosis has not been till date specifically targeted. So for targeting inflammation, now we have finerenone, that is the non-steroidal MRA. So in the recent Fidelio and Figaro studies, it was shown that addition of non-steroidal MRA, that is finerenone, resulted in almost 20% reduction in the risk of progression of chronic kidney disease. It also resulted in lower risk of developing heart failure for these patients also. When we should be adding finerenone to our patients, the patients should already be on ACE inhibitors or ARB. All the studied patients in the Fidelio and Figaro study were already on maximally tolerated dose of ACE inhibitors and ARB. This needs to be kept in mind, because if we are treating only with finerenone without adding ACE inhibitors or ARBs, our patients will not be obtaining the full benefit of the combined therapy. The patient should have a eGFR of more than 25 ml per minute per 1.73 square meters, and their serum potassium should be less than 5 milliequivalent per liter. Whenever we are adding finerenone, we should be monitoring the serum potassium for our patients frequently. At least once we add finerenone, we should check. We should start finerenone at 10 mg per day. It is a OD dosing drug. After starting finerenone, we should recheck the patient's potassium at 1 to 2 weeks interval. And if the potassium is stable, then we can continue finerenone at the same dose for next 1 month. If after 1 month also the potassium remains below 5, we can increase the dose of finerenone to 20 mg if the patient tolerates it. So, thus far, we have discussed the three pillars of therapy to halt the disease progression in chronic kidney disease with type 2 diabetes, where we have RAS blockade, SGLT2 inhibitors, and non-steroidal MRAs. The addition of all these three agents can significantly reduce the progression of chronic kidney disease. They can reduce the albumin-urea and ultimately give our patients a better chance of protecting their kidneys. The other gaps that need to be addressed for our patients is there a role for combining finerenone and SGLT2 inhibitor therapy. In the Fidelio study, there were very few number of patients with SGLT2 inhibitors who received finerenone. When we combine all the three therapies, that is RAS inhibitor, SGLT2 inhibitor, and MRA, that is mineralocorticoid receptor antagonist, we need more studies to see how these patients do behave and how we can address what more can be done for our patients with type 2 diabetes and CKD. The fourth pillar that we recently have got for our patients with CKD and type 2 diabetes is the semaglutide, that is the GLP-1 receptor agonist. In the recent FLOW study, semaglutide was shown to reduce risk of clinically important kidney outcomes and death from cardiovascular disease in patients with type 2 diabetes and chronic kidney disease. So with the addition of semaglutide to our armamentarium, we probably now have the four pillars for better management of chronic kidney disease in patients with type 2 diabetes. Semaglutide currently is available in India in the oral form, in the form of 3 mg, 7 mg, and 14 mg as a drug. And another agent that we have is liraglutide, which is an injectable preparation that we have available for use in our patients. Semaglutide is a costly therapy, and generally many patients may not be able to afford the therapy as of now in our clinical practice. But whenever we find a patient who is suitable, who is mainly in patients who are obese and who have multiple cardiovascular risk factors or comorbidities, they are candidates for receiving semaglutide. But the semaglutide should always be prescribed and should be monitored by a expert physician who has a keen knowledge in using semaglutide, because it is an agent that is not free of side effects. And there are multiple effects, and there can be multiple factors that need to be addressed when patient is on semaglutide. So, to conclude, diabetic kidney disease is a major cause of chronic kidney disease in India as well as the world. With increasing number of type 2 diabetes patients in India, we have to be more and more aware of risk of chronic kidney disease. And earlier, the better. Where we pick chronic kidney disease at an early stage and initiate remedial therapy at an early stage, we can reduce the progression of chronic kidney disease, and we can give our patients with chronic kidney type 2 diabetes a better life, and we can reduce their morbidity, we can reduce their mortality. There are upcoming new agents, and probably the coming decade will be the most exciting for appropriate or better management of patients with type 2 diabetes and chronic kidney disease. There are some myths about diabetic kidney disease that we need to be aware of. There is a common concept among patients as well as we as physicians that progression of diabetic kidney disease is inevitable and there is no treatment for CKD. But the fact is DKD can be prevented and progression can be, even if not prevented, at least progression can definitely be slowed by whatever the factors that we discussed till now. DKD is equally common in patients with type 1 as well as type 2 diabetes. We are increasingly seeing type 1 diabetic patients landing up with chronic kidney disease and requiring renal replacement therapy. DKD, as we discussed earlier, also generally has associated diabetic retinopathy, but there can be some patients who may have diabetic kidney disease. We have quite a few patients who have biopsy proven diabetic kidney disease even in absence of diabetic retinopathy. Albuminuria may not always be present in patients with diabetic kidney disease. There can be patients who are normoalbuminuric even with when having a reduced GFR. All patients with DKD should be seen by a nephrologist. It is an ideal situation where a nephrologist monitors all these patients, but with limited number of nephrologists and very high burden of disease, even primary care physicians can very well manage a diabetic kidney disease patients who has a stable kidney function ongoing. In patients who have a rapidly worsening GFR or who have other comorbidities, these patients can be better managed by a nephrologist. Thank you for patient listening. If you have any questions, I would be glad to answer them. Thank you.
Thank you, sir. Thank you so much for the beautiful presentation. Now, I would like to take a few questions from the audiences that has come the way. The first question is, how might emerging technologies such as precision medicine and genomics impact the management of diabetic nephropathy in the future?
Uh, Precision medicine will definitely help. What we are seeing now is also a degree of medicine where we are seeing we already had spironolactone or eplerenone in our management, but the development of finerenone is an outcome of precision medicine where a new molecule that was what we call a fat molecule, non-steroidal structure of mineralocorticoid receptor antagonist, finerenone was discovered and was shown to be beneficial in patients with diabetic kidney disease and with a much lesser incidence of hyperkalemia. So precision in medicine definitely will benefit our patients. Genomics, we are still not sure how we can incorporate genetic factors in the management of chronic kidney disease at this point of time as respect to a patients with type 2 diabetes. But as we discussed in one of the slides, the presence of APOL1 gene, that is apolipoprotein 1 gene, has been shown to be a marker of chronic kidney disease in African patients. So we might get more number of markers which are more appropriate for our patients, the Asian or Indian population, which may guide us to address them better. But as of now, probably genomics in type 2 diabetes and chronic kidney disease is not that developed a field to comment upon.
Okay, sir. Right, sir. Thank you so much for answering the query. Next is, what are the recommended blood pressure targets for patient with diabetic nephropathy?
Very important and pertinent question. So there are various recommendations from various bodies. And there is a bit of a difference. So European guidelines, they say the patients who does not have proteinuria, they have a separate target. For a patients having albuminuria, they have a separate target. For patient with progressing CKD, they have a different target. But as a general rule, if we have to apply a patient who has type 2 diabetes and chronic kidney disease, we should be targeting a blood pressure of probably 130 by 80 millimeters of mercury. One important factor in this I would like to highlight is in patients who have limited lifespan or who have chronic, who also have concomitant CVD, mainly the elderly patients who are more likely to have postural hypotension, where if we are having too tight blood pressure control for these patients, they may have orthostatic symptoms which may increase their propensity to fall and leading to other comorbidities like fractures. So in these patients with limited life expectancy or who are very high risk for orthostatic hypotension, we probably can have a little relaxed target of probably 140 or 150 millimeters of mercury. But majority of the patients, a target of 130 by 80 millimeters of mercury is what we should be trying to achieve.
Right, sir. Thank you so much. We have last question for today. That is the impact of diabetic nephropathy on the progression of other diabetic complications like retinopathy and neuropathy.
Diabetic nephropathy majority of the times is associated with presence of other end organ damage like retinopathy and neuropathy. Diabetic retinopathy patients, means any patient with diabetic nephropathy should definitely be screened for presence of diabetic retinopathy, and if we have he or she has retinopathy, it should be addressed with adequate measures. Another interplay of things between retinopathy and nephropathy is use of VEGF inhibitors, the bevacizumab or related class of drugs, where these drugs are used for treatment of diabetic retinopathy. There is some data to show that these use of these drugs may increase the patient's risk of developing proteinuria or worsening in the GFR or chronic kidney disease, but there are conflicting data. So this is another factor that we have to be aware about or wary about in these patients. Neuropathy in patients with type 2 diabetes and CKD can both be related to diabetic component as well as the CKD components, because even non-diabetic CKD patients are more prone to develop neuropathy. So again, presence of diabetic nephropathy or diabetic kidney disease has an implication for both retinopathy as well as neuropathy.
Right, sir. Thank you, sir. Thank you so much. These were all the queries for today. So I would like to take this opportunity to thank you for giving us your precious time and sharing the piece of wisdom with all of us. And of course, thanks to all the audiences who have joined for the session and made it a successful one. So with this note, sir, we would like to conclude the session today. Thank you so
Thank
much,
you.
sir.
Thank you, IBC.
Thank you, sir.